Hello, and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Sarah Anderson. In this episode, we'll be hearing a discussion about practical strategies to incorporate PTSD and trauma screening, diagnosis, and treatment into the care of people living with HIV. For this episode, I'm joined by Dr. Tristan Barber from the University of College London and Dr. Glenn Treisman from Johns Hopkins. For more information about this program and to follow along with the accompanying slides, please visit the links in the show notes for this episode. And to get access to all of our new infectious disease podcast episodes, subscribe to the CCO Infectious Disease Podcast channel on Apple Podcasts, Google Podcasts, or Spotify. Now, let's get started and hear from Dr. Treisman.
Hello, everybody. My name is Glenn Treisman. I'm a professor at Johns Hopkins University School of Medicine. And today we're going to talk about PTSD and trauma care as an integral part of HIV care. This is a program for clinical care options, and we really appreciate getting the opportunity to do this program for you and clinical care options supporting us. With me today is Tristan Barber, who is a consultant in HIV medicine at the Royal Free London NHS Foundation Trust. He's at University College London and is one of the people interested in the psychiatric issues in HIV. His work is nationally, internationally known, and he's an outstanding expert on PTSD. So I thought we would talk about that. I wonder if you would start us off today, since we're talking about PTSD, telling us how you think about PTSD as a disorder.
Thank you very much for the question, and it's a great delight to be here for this session with you, Glenn. I think for me, it's a classic example really of how an individual responds to environmental challenges. I think most of us, no matter how psychologically robust we are, could be overwhelmed by very extreme circumstances and experience PTSD. I think some people probably have a lower threshold for being overwhelmed, but for me, certainly, I think the sense of overwhelming is really the key in terms of this disorder. I think people become completely overwhelmed with a circumstance that then they ruminate on, and that becomes really all-encompassing and really difficult to move on from. Where people are on that spectrum in terms of their ability to cope, their psychological reserve obviously varies. And so I think it's a mixture of understanding the precipitating trauma, but also, of course, understanding the subtleties of the individual who's experienced that when trying to make sense of where they need to go to heal or to improve, or to at least be able to park some of their symptomatology so that they can cope with everything else they have going on in their life.
That's a very helpful place to start. So Tristan, you're going to present a case to us, and we're going to talk about your case a little bit, and then think about together how we can help our colleagues understand and think about PTSD. So if you would proceed with your case, that would be lovely.
Sure, thank you. So I yesterday saw a 50-year-old man who was previously under our care, has disengaged from HIV care for the last 2 years. He has a very high level of viral replication. He's currently immunocompromised with a CD4 count below 200. And essentially, his story is that just over 10 years ago, he was traveling outside of the UK in Asia. He was imprisoned for accused of essentially a serious crime. And essentially, that experience has really overwhelmed the rest of his life. He's found it very difficult to reintegrate into normal living back in the UK. He has struggled, therefore, to engage as well with healthcare, both mental health care as well as his physical and HIV care in addition. And when he is in the room, you have a sense that he's sort of semi-present. So he can talk in the now, if you like. He can talk about where he is currently for a couple of sentences, and then he very quickly relapses into talking about his previous trauma. So reliving experiences that he experienced when he was incarcerated, and trying to take you back with him really on that journey. So it's quite difficult to center him in where he's at currently, what the current issues are, and how we can help support and address those. He has a history of substance misuse. He feels that's under control at the moment. He continues to use crystal meth when he feels completely overwhelmed, and at the moment is not willing to engage with seeking any support in terms of reducing or stopping using crystal methamphetamine. So that, I think, makes it difficult to engage him into good counseling, good mental health care, and try and address some of the issues that are the root cause of his current problems. So we've got some kind of biological issues in terms of managing his currently untreated HIV, but really this overwhelming, as we've mentioned before, using the word overwhelmed, but this overwhelming history of trauma that really occupies much of his attention, much of his waking day, and I think really disrupts his ability to conduct activities of daily living successfully. And overlaid with that, of course, some substance use, which makes it very difficult for us to engage him into good mental health care and support.
What does he say he gets out of the crystal methamphetamine? How does it help him?
He describes feeling, I think, fatigued and overwhelmed by making many complicated decisions. And I think even though the crystal meth, of course, deprives him of sleep and disrupts his mood, I think what it does give him is a lot of focus. I think we sometimes see this, that perhaps people are self-medicating with some stimulants, including crystal meth, to treat underlying ADHD, for example. And I think there is an element of that for him. It helps him focus at the time when he's using it. So it helps him achieve individual tasks that he needs to get through.
Well, that's an extremely interesting case. Both you and I have seen many cases of people with these traumatic experiences. This is a particularly good case because it illustrates one of the things people have trouble with, which is, where do we draw the line between somebody having a normal reaction to a life circumstance from somebody who is disordered by an extraordinary life circumstance like this fellow? So I thought we'd just for a minute talk about the HIV clinic and PTSD and talk a little bit more about your patient. So PTSD is very common in our clinics. Some people say that in HIV clinics, 3/4 of the patients have had some significant trauma that affects their response. What are the things you look for when you're thinking about trauma in our clinics?
I think there can be multiple examples of things that have caused traumatic experience. I mean, I think to an element in an HIV service, I think everyone has experienced some aspects of trauma. Even an HIV diagnosis itself can be traumatic. We, of course, do see people who've experienced sexual assault. We see people who've experienced relationship breakdown. We see increasingly commonly people with very extreme experiences of illegal drug use. Certainly crystal meth is a huge problem in London, and we have particularly gay and bisexual men who have sex with men who may have witnessed people becoming very unwell using recreational drugs, including other drugs like GBL and GHB. We've got people who have suffered bereavements amongst their friend groups from people that have overdosed on recreational drugs and are experiencing a lot of trauma from that because of the way it's affected their community and them individually. And also we see a lot of people in our clinics who've arrived in the UK from overseas who may have experienced trauma in many different country settings and arrived here either seeking asylum or migrating for other reasons. But we do see a wide range of people who've experienced trauma in a number of ways. And as I say, I think we can't underestimate the fact that for most people with HIV, even if we just take the time of diagnosis or the time of HIV acquisition, that in itself can be an overwhelming trauma. So multiple reasons.
One of the struggles with PTSD has been the historical kind of politically contentious issues, shell shock, soldiers' heart shell shock, battle fatigue, and then PTSD through various wars. And much of what we learned about PTSD has come from combat-related disability. Do you think about that a lot in our work? Because I don't find that as useful.
It's a really good point. I think the people that were diagnosed before 1996, so the people that were diagnosed before we had successful triple therapy, the people that were told, cash in your pension, sell your house, do the bucket list, you have a 5-year life expectancy, the people who'd seen friends and loved ones die, I think that was a war. That was a battle time. Those people do have experiences that were like coming through a battle or a period of war, because they were fighting for their friends. They were fighting to get access to drugs. They were fighting for services. They were often fighting for social care and social support. So I think those people really do have a sense of having fought a war that is sometimes analogous to that battle data. But fortunately, for people that have been diagnosed more recently, I think those data sets are less relevant. and less connected. But I think there are some aspects of it that do apply to those very long-term survivors who, continue to suffer from the trauma that they experienced in the late 80s or early 90s.
Yes, it was very interesting. I saw a fellow who come to the U.S. from Britain, and part of the reason he moved to the U.S. is at the beginning, when we were using triple therapy, Britain started out by using double therapy, and he said he found that incredibly traumatic, that there was a benefit from 3 drugs, and he could only get 2 drugs, and thought that was very alienating for him as an event. And many of the patients, like you say, from that era, talk about specific, very alienating events. Doctors telling them that they were going to die and there's no point getting off drugs. Doctors telling them that they had a very short lifespan. And one of my patients brags about the fact that her doctor told her she was going to die within 2 years. She's now been my patient for 38 years.
Yeah.
And her physician died 30 years ago. She still brings it up almost every time we see each other. So let's talk a little bit about the definition of PTSD and how you think about a diagnosis. I learned that people have a trauma. They have 3 basic critical elements to it. One is the intrusive re-experiencing, one is the social avoidance, and one is the increased arousal and reactivity and sort of sympathetic overactivation. How do you think about diagnostics for these patients?
Yeah, I mean, exactly as you've mentioned, we're very lucky in that I'm an HIV physician. We have a dedicated HIV psychology team and a liaison psychiatrist here within our clinic. We care for, I would say, a group of people with HIV who are older than many other clinics I've worked in the UK. So we've really fought to retain both psychological and psychiatric support within our clinic. So I tend to refer to my team, who are fantastic at seeing people really quite quickly, particularly if we're concerned about a diagnosis of PTSD, and they will make the diagnosis. But I agree with you completely. It's the factors that you've mentioned, and also the disruption. So this person I saw yesterday is really a fantastic example, because as I said, it's very difficult to get him to be present, and the rumination and the intrusivity of his memories really have taken over him being able to deal with things that he needs to deal with now and currently. So I actually saw him in tandem with one of our psychologists so that we could get things started really early.
The intrusion is a very good word. I sometimes leave that word out, but the re-experiencing element is intrusive into the present. It's very difficult for patients to immerse themselves in the now without intrusion of these experiential thoughts coming in, and almost anything can trigger them. And things from the environment when you're seeing them, things from the environment when they're out, will trigger a cascade of distressing recollections. The other thing I think a lot about is the avoidance issue. Many of these patients become very socially isolated. Our patients have a great deal of trouble reintegrating, as you say. My one patient is sitting in his apartment most of the time and is visited by the ghost of his girlfriend who overdosed. And it's him and the ghost of this ex-girlfriend who he has tremendous survivor guilt about. And he doesn't go out, doesn't do anything else except come to clinic.
Well, the other thing we kind of see, which I think is interesting, is that very often these people struggle with adherence to their antiretroviral therapy. But actually, when you speak to some people directly about it, sometimes they're having this reverse idea of control. So the one thing they can control is actually, I'm going to decide not to take my meds for now. It's kind of a reverse, it's a decision in the wrong way, if you like, but it is a form of, I can't control so much else, but this is something I can control by making a decision that for now, I'm going to avoid meds until, and often it's bargaining, right? So often it's until you fix this for me, and then I'll think about meds. Until this, I get the new flat, or until I'm a bit more financially secure, then I'll be in a place to take meds. Now, we know, of course, having all those basic needs met is very important to adhere to medication for a long-term condition. But I've been able to use that successfully sometimes, because by challenging that kind of reverse psychology, it's like, I understand you've got control over this, but you need to use the control in the opposite direction. You actually need to use the control to keep yourself physically well, so that we can then work on the mental health and everything else that you've got going on. And I've seen that quite commonly. I don't know if you've seen that.
Oh, absolutely. And so everybody has their own style of interacting with patients. I'm a tremendous believer in confrontation with a smile. I point out to patients, I'm trying to get you better, and you're not trying to get you better. That's a pretty unfair deal. We both have to pull on our oar for the boat to go anywhere. So if I'm pulling on my oar and you're not, the boat will go in little circles. So your job is to pull on your oar and I'll pull on my oar. You want me to pull harder on my oar, no problem, but you have to pull harder on your oar. That conversation is pretty, I have that conversation a lot with patients, both PTSD patients and also patients with chronic pain disorders where we're trying to rehabilitate them. So how important is it to think about depression in these patients and mood disorders? And how do you think about that?
It's an easy answer. The answer is yes to the first part. How do you think about that is slightly more challenging, I think. I think anxiety is in some ways, I mean, someone who's very flat and depressed, in some ways you can pick that up more easily. I think it's the anxiety that can get hidden a little bit in some of the other symptoms of PTSD. And also the fact that very often people are self-medicating with recreational or over-the-counter drugs or sleeping medication, etc. So I think teasing out the anxiety component can actually sometimes be harder than recognizing true depression.
Yeah. Do you generally tend to overtreat? Because I'm a great believer in overtreating. When I can't figure it out, I say the side effects of taking an antidepressant are so trivial compared to the side effects of inadequately treated major depression that I'm an aggressive treater.
Yeah, I would say we're exactly the same. I think it's just important to review things. And of course, we're seeing these people, trying to see these people really quite regularly. So, of course, over-treating in the early stages can be helpful, and then reviewing things and obviously deprescribing as and when you think things are not contributing in a positive way can be really effective. But I think this is a situation where there's no point holding back in the early stages.
Well, you brought up a point just now that I wasn't going to bring up, but I think is really important. How often do you see patients when you're starting with them with this condition?
I tend to see people about every 6 to 8 weeks for the first sort of 3 to 6 months, if possible. Sometimes people struggle to come in that regularly. And if things are improving rapidly, then I might see them a little bit less often. But of course, it also has to be balanced out with the other appointments they're having. So they might be seeing me, but they might also be seeing a psychiatrist and our psychology team. So if we're able to try and minimize the complexity of those appointments and sometimes, double up, then we'll do that so that they're not having to come in too frequently. But I think keeping a regular contact is really, really important because you can see, of course, first of all, you want to see progression and try and deal with things as they arise. But secondly, of course, you can review medications, stop things that are not helping or indeed are causing excess side effects or modify doses. And also it helps just to build a therapeutic relationship with the individual because if they know you're accessible, they know they can see you regularly. I think the trust starts to build. If you give them pills and say, come back in 6 months, there isn't really that opportunity to really develop the kind of deep trust that you need here, where they really feel understood and listened to, and they feel they can access you for things as they change, or indeed reveal new information or information they didn't feel comfortable sharing with you at baseline.
Yeah, I think that's just an incredibly important point. So I am the psychiatrist psychology team that you would be referring to in our clinic. And so we see patients back in 1 to 2 weeks. And often in 2-week intervals, sometimes even in 1-week intervals, because they're not sleeping. And I say, first thing, got to get you sleeping. So I need to know if these medicines work, because if they don't, I'm going to change them till you're sleeping. And I need to know if you're doing the stuff you tell me you're doing so that I can amend it so that you can do it. Often I will try to get people to give me a pharmacologically level playing field. And I'll say, well, I do have a medication that might really help you sleep, but it doesn't go well with stimulants.
Yeah.
If you want to sleep, you have to give up the stimulants for a while we get you sleeping. Because you could die if I combine them, I need to know that you're not using stimulants. And I'll have them come in for tox screens, and I'll discuss what's going on with them each week. But it's only at the early parts of treatment, but it does build up a sense in the patients that you're very committed to getting them better, which often is something they have lacked.
Yeah, and you're right. I mean, I should say, as I did mention the team, and you're right in that I think, frequently is good. I guess my 6 to 8 week is really that kind of medical oversight in between the other appointments and support that they're attending for. So, yeah.
So often one of the troubles we have in our clinic is patients will come and see us, but not go see their primary doctor. The double up thing that you mentioned, I will see patients, if I possibly can, with their provider when they come, and vice versa. They will see them with. So I'll say, it just so happens that Dr. So-and-so is here today. Let me go get him and we'll bring him in here and we'll just make sure that we're all on the same page about whether or not you should take your medicine every 3 days or whether you should take it every day. Are you finding the long-acting drugs useful in these patients, long-acting HIV drugs?
Not in this specific scenario at the moment. I think we've still been building confidence with long-acting injectable antiretroviral therapy, and it tends to be so far that we've been using it in those people who are perhaps a little bit more stable, who we know can attend for regular appointments for their injections. And I have to say that in some of the people we're talking about here, the PTSD cases, people are often missing appointments. They're not attending so regularly. And I think we still worry about people who miss injection doses. So yeah, not an area we've built up a lot of experience in as yet.
It is a bit of a double-edged sword. On the other hand, I have a lot of patients who say, every time I swallow those pills, I'm re-experiencing knowing that I have HIV and that I'm living with that every day. And if I can get an injection infrequently, that would be better for me. And then I think about whether or not that will keep them from coming into the clinic or improve them coming into the clinic.
So actually, you've reminded me of a case that I did have of someone very early on who requested injections, and at the time revealed I'd actually taken over his care from someone he'd been seeing previously who'd left, and he disclosed to me that he'd acquired his HIV through a sexual assault, that he'd had counselling at the time. It felt like he dealt with it, but actually his daily tablets were the one reminder of that sexual assault. So he really felt that going on to injectable antiretroviral therapy would liberate him from that. So that's someone for whom, as you have mentioned, that it can be liberating, in fact, to get rid of daily oral treatment.
The other thing is it's quite stigmatizing in our community in Baltimore to have HIV. And for many patients, that stigma is associated with taking HIV medications. I can't sleep out because my medicines are at home. I don't want to take my medicines in front of a stranger. If I could just know that I couldn't infect anybody and that I could, those kinds of arguments. And I think in PTSD patients, often those are more relevant rather than less. So let's talk for just a second about substance abuse and comorbidity. I mentioned major depression. I think that probably is a comorbidity that affects about 3/4, maybe more, of my patients with PTSD. I'm aggressive about treating it. Tell me a little bit about how you think about substance abuse. You mentioned self-medicating, and I think that it is a very, very common comorbidity for PTSD to have substance use issues. How do you approach that with patients?
I think substance use is a really problematic issue that we, really need to keep high on our radar in people with HIV. In London, and I know we're not unique, in many other cities, in gay and bisexual men who have sex with men, we continue to see a lot of use of chemsex drugs in particular, so crystal methamphetamine, methadone, and GBL or GHB in combination. We have a number of people who are quite chaotic who attend our service, particularly crystal meth users, who can come in sometimes quite intoxicated and often do have a history of PTSD or of a severe mood disorder, particularly depression. As I've mentioned already, some probably, even if not formally diagnosed, also have a diagnosis of ADHD. And of course, this can really impact on their medical outcomes, both in terms of being able to attend for appointments, take medication regularly, but also can impact on their ability to self-care in addition. And then I think even outside of that particular example of chemsex, we continue to see quite a lot of, I think, low self-worth in some people with HIV, quite a lot of nihilism, if you like, sometimes, that even though they're taking their HIV treatment, some people will, have a feeling that, they're kind of almost not, sometimes a feeling of not very high self-worth, I think. And so there'll be some poor behaviors in terms of perhaps alcohol use or the use of other recreational drugs in addition. And so kind of unpicking all of that, looking for a true underlying mood disorder, including depression, but also looking at low self-esteem because of course, that it may be what put them at risk of acquiring HIV infection in the first place, maybe unresolved issues about sexual orientation, about gender identity, about sexual behavior, or indeed just about sex in general. So I think trying to unpick some of the factors that may have perhaps led to HIV acquisition in the first place, but that then continue to play out in terms of the way that someone approaches living with a lifelong condition is very, very important. So we will screen everyone for depression and anxiety on an annual basis as part of one of our clinics is a nurse and pharmacist, specialist pharmacist-led annual review clinic. And when people attend that clinic, they are screened for anxiety and depression. If they score on the screener, then they go up to a more detailed investigation. If they score positively on that, they are engaged with our psychology team. So important, I think, to have approaches to continue to be vigilant for mood disorders, but also for substance misuse in all people who are living with HIV infection.
Do you screen people for PTSD? Do you examine everybody? Do you take a full history from everybody? Do you use these screeners? Because there's quite a number of them, and we've recommended them to other teams where they're really not going to get into the depth of history that we do as a standard. But do you do these primary care screeners, PTSD-5 and the SPAN and those things?
No, so this is really interesting to me because actually we're not using routine screeners for PTSD. We, if you like, these are being done once someone's already being identified to clarify things a little bit, again, by our psychologists, but we're not routinely screening for PTSD in all of our clinic attenders who are attending for routine HIV care. Maybe that's something we need to think about.
Well, it's certainly something that people have pushed, and I can't comment very well on it from my point of view because we, of course, take the average intake visit for us is an hour and a half. And we really get into the details of patients. One of the things very interesting, and very early on when we were starting psychiatry service at Johns Hopkins in the 80s, there was a big objection to the fact that I took an hour to an hour and a half with patients and saying it's too much of a burden for them. And what we found is the next visit show rate, if we evaluated people, went up. So the next visit show rate in the clinic was 50%. And people who had an extensive screening interview with us, it went up to 75%. And when we asked patients why they'd come back, they said, well, they spent an hour and a half with me. The only time I've ever seen a doctor for longer than 10 minutes. And so these supposedly intrusive conversations with patients can be intrusive, but they also are a way of showing how concerned we are and how thoughtful we are about each patient. So I do think, though, that in a situation where you have brief visits and you're just getting going with patients, screening is probably a very reasonable thing. And there are a number of the screeners, and I urge people who are setting up HIV clinics and in HIV clinics who aren't doing it to think about those screeners. And then many of those screeners have been built into measurement-based outcome instruments where you can ask people about their symptoms and see if they're getting better. And I don't know if you use any of those. We do not, again, use them in psychiatry service because we're asking people about how often they're going to the store, and each patient is quite different in terms of what our goals are for that person. Getting somebody to go to their local church could be as important a thing as anything else we do, just to try to hook them up. Do you do any of that? Do you do the life events checklist and that stuff?
We don't. To my shame, we don't yet. So I think you're really stimulating some ideas for me here about looking at how these might be implemented actually in clinic population and what outcomes we might see from using them. You hit on a really important point for me, though, which I think is crucial for all HIV providers. It's the idea of time. And it's about individualizing your approach, right? So some people want a 10-minute appointment. Some people are super well. They've got busy jobs, they've got busy lives. They want to come in, they want to get their meds, they want to see what their blood results are and go. And by seeing some people or knowing your clinic population and, freeing up some time from those people who are stable, who really want quick appointments, you can give the other people who are more complex more time. And sometimes, as you've identified, it really is just having that hour, an hour and a half to really listen to people that really engages them and allows them to go to places that they've not been before. And really, as you mentioned before, some people may not be seeing their primary care provider because often it's the HIV service that they trust the most. So I think we really do people a disservice if we try and see everyone with HIV in an equi-sized appointment, 20 minutes or 15 minutes. I just don't think that's the right approach for everyone. For some people, they want less, and some people just need more time with the person they really trust and who they feel really understands the holistic nature of their HIV, but in the interaction of that with their mental health, with their other physical conditions. So time, I think, can, in a way, be one of the best screeners. And then working out how you use the tools, some of the tools you've mentioned, is something that can be individualized according to your own expertise and what you have in your own clinic, or what mix of staff you have. But time, I think giving some people time is really the most important first step.
Yeah, So I do things just the way you describe. Our clinic, each patient gets what they need. Some patients don't want to spend more than a few minutes. Other patients really need some time. So that leads us into treatment. Talk to me a little bit about how you think about treatment. Do you have groups in your clinic? Do you have individual psychotherapy for patients?
Yeah, we have individual short-term psychotherapy. So people can have up to 12 sessions of psychotherapy in our clinic. If they need more ongoing care, they will need to be referred out into community or more specialist services in the UK. So we're only able to offer some fairly time-limited but individual psychotherapy. We are able to obviously support people with appropriate medication. We don't have, I have to say, within our service, specific groups for work in this area. So we would be looking outward for groups provided elsewhere to refer people into those groups if we thought that was the appropriate route.
Yeah, and so what some of the things we do have this idea of combining exposure, cognitive processing, and cognitive behavioral therapy into a PTSD directed comprehensive therapy. We found referring people out it fails. So we did this study. We looked at 100 patients we referred out very early on, and 0 of them went to their follow-up. Of 100 patients we referred, we called them, we reminded them it was in the same building, and they still didn't go. So we just have decided that we have to keep this in the clinic as long as we can get the resources to do that. And we follow our patients. We have patients we've been following for the entire duration. I have patients from my first 2 years in the clinic still seeing me. That was 1988. So we haven't been very successful in transitioning people, much more successful in keeping them in care in the environment. So thinking about what you do with patients, we do a lot of cognitive behavioral therapy, both trauma and non-trauma focused therapy with exposure, talking about the experience and thinking about how to cope and rehearsal. So pharmacotherapy, you guys use medications. Presumably, what things have you found most useful? What things have you not found much useful?
Yeah, I think like most people, we're using very commonly used drugs that are approved for the use of treatment of PTSD. I agree, SSRIs can be useful for some. I think it's very important to, as we've mentioned before, make sure that you're also taking into account any underlying mood disorder. We do find mirtazapine can be very useful for people that have insomnia as a predominant feature. So we're finding people that have sleep disorders, mirtazapine can really be helpful. And actually, mirtazapine can be very useful in replacing other things that people are using for sleeping. So trying to wean people off zopiclone, zolpidem, etc., that they may be obtaining outside of the clinic or obtaining from non-prescribed sources. So I think mirtazapine really can be very useful in that situation for us. What are the drugs you're finding most useful?
Yeah, well, we're doing much the same thing. I would put in a plug for 3 things that we underutilize. Mirtazapine being one of the things that you mentioned. I think it's a very useful drug that we often overlook. Do you use prazosin?
No, not really, actually.
So sometimes for sleep, and particularly the intrusive nightmares, prazosin is useful. I mean, it's one of the armamentarium things I use for sleep, along with drugs like tricyclic antidepressants, which I think are underutilized a great deal, and trazodone. The other thing I wanted to mention in passing is sleep is very important to patients. And Phenergan is a neuroleptic. You don't know that Phenergan's a neuroleptic, promethazine. It's used for nausea. But many times people will resist the idea of taking an atypical antipsychotic drug, even though they augment tremendously the effectiveness of antidepressants. But they will take Phenergan perfectly. They'll take promethazine perfectly happily, great for sleep, and often will augment your antidepressants. I do want to mention, though, that we underutilize tricyclics. You have to be an expert. You have to know about the blood levels. But nortriptyline, doxepin, and even protriptyline are underutilized in our clinics. I think you guys don't have protriptyline, right?
I don't think we do.
Yeah, it came out at the same time as fluoxetine, as Prozac, so it didn't get picked up very much. We use it occasionally, much more nortriptyline, which is available there.
I'm also seeing for subtle sleep problems, I'm also seeing a lot of increased prescribing of melatonin, actually. Our psychiatrist is using more melatonin, which obviously can also be useful.
Yeah, there's a lot of conflicting evidence about prazosin. So in the trials, prazosin was not found to be better than placebo, but in certain patients, it's clearly better. And so I always tell people to think about it. And again, some patients really like it. And then I think that the last thing is are there things that you run into that are really derailing in terms of patient care?
I think the most derailing thing that can happen in terms of patient care is fragmentation, actually. So, people who, for various reasons, miss their appointment, they then try and come on the day that you're away or the day you don't have clinic, and they see someone else who slightly changes the therapeutic approach, or they, drop out of their psychology sessions and find it difficult to re-engage. So I think anything you can do to support people in terms of continuing to engage in care and to try and see, as you've mentioned, to try and see the journey through, really ensuring that you're both pulling on the oars to go in the right direction, and helping people to understand that the most important thing is to try and keep one foot in front of the other on that journey. I think it is fragmentation that makes it very difficult. When you go back to having to restart the process all over again, I think that can be really, really disruptive.
Yes, integrated versus disintegrated care. We try to integrate at a variety of levels. One of the things that we do that I always recommend to clinics is this. My clinic is on Mondays, and on Mondays, if you show up, we will see you. Monday's not timed. The rest of the week, if you have a 2:30 appointment, you're going to be seen within 5 minutes of that appointment. But on Mondays, you may have to wait 2 hours to see me, but we will see you. So patients who are having trouble with the structure of having on-time appointments get moved to Mondays, to my clinic. And on Monday, we have a very, very large number of clinicians in-house to see patients. And then the other thing I press people on is to try to keep things integrated. That is, HIV-infected patients need psychiatric care that is integrated into HIV, and HIV care that's integrated into substance abuse, and substance use that's integrated into both. And this idea that they can be separated out and people can be sent, you have a muffler shop and a battery shop and a tire shop, but if you do it that way, if there's something wrong with your car, no one figures it out because they're only selling that one part of the treatment. I think that integrated care is key, which you mentioned, keeping people in a coherent treatment program.
I think some flexibility is important. We tend to have one floating doctor in our clinic. So we have booked appointments, and then we have someone who's flexible across the week, actually, for exactly the reason you've mentioned, so that anyone that turns up can be seen. They may have to wait. I think I'm going to think about introducing some routine screening. We might do a pilot project in our own clinic to see how that goes and see what we pick up in combination with our psychology team. I think having a high level of awareness that people with HIV experience a higher burden of PTSD is really the first step. And then looking at how you implement detecting that or supporting people in your own clinic environment will really need to be individualized according to your own cohort and your own resources. But thank you very much indeed for the great discussion.
Right back at you, Tristan. I really appreciate you being willing to do this for us. I really appreciate the work you do. It's really very inspiring. So thank you for the work you do.
And you too. Very welcome. Thanks.
Thank you, everybody, for coming to this Clinical Care Options program.
Thank you very much to Dr. Barber and Dr. Treisman, and thank you to our listeners for joining in. As a reminder, to view the full program on Remind, Making Mental Health Care an Integral Part of HIV Care, on the Clinical Care Options website, click on the links in the show notes for this episode. And to access all of our new podcast episodes, subscribe to the CCO Infectious Disease Podcast channel on Apple Podcasts, Google Podcasts, or Spotify. Thank you and have a great day.